Hello, thank you all very much for having me speak today. As you said, I'm from Florida Atlantic University, and I'll be talking about the differences in adjunctive anesthesia during colectomy when compared to general anesthesia alone. None of our attendings have any relevant financial disclosures for this presentation. So based off of the ERAS guidelines that are published from 2018 and then again in more recently, spinal anesthesia is, with low-dose opioids, gives good analgesic effects, has stress reduction properties, allows postoperative opioid sparing, and is recommended as an adjunct option to general anesthesia in laparoscopic surgery. They deem this a moderate quality of evidence with a strong recommendation. Based off of a couple randomized controlled trials, when compared to standard of care or PCA, spinal anesthesia is associated with lower postoperative opioid usage, earlier time to meeting discharge criteria, but not necessarily earlier discharge. The study that evaluated that used a metric of a standardized criteria for when a patient was medically fit for discharge, rather than the actual date of discharge from the hospital, and then lower perioperative pain scores on the 10-point VAS scale. Technique, this is done by anatomic guidance, lumbar region only to avoid hitting the spinal cord itself and causing trauma. It's an injection of local anesthesia in the intrathecal space, so there were also studies that evaluated epidural anesthesia. We didn't include those here because it wasn't utilized in our patient population. And it provides analgesia predominantly below the umbilicus, but it depends on the level of the block, the strength of anesthetic used, and the quantity, because it can spread within the spinal column and cause higher levels of analgesia. The other guideline relevant to adjunctive anesthesia is looking at TAP block, which is the transversus abdominis plane block. A couple small RCTs again showed benefit here, with the effect depending on the technique. There's both anterior and posterior techniques showing decreased opioid use and increased recovery. Again, the recommendation was moderate with a strong recommendation with a moderate quality of evidence. These two are both recommended as options as adjuncts to general anesthesia. The guidelines don't have any specificity over which is preferred or if there is a preference. They leave it up to institutional discretion. So TAP blocks, when compared to local analgesia, is what most of the studies looked at. Lower postoperative opioid usage, less nausea, and shorter length of stay. This is often done with ultrasound guidance, although there have been laparoscopic techniques demonstrated. It's injection of local anesthesia in the plane superficial to the transversus abdominis muscle, and it typically provides analgesia from around the T9, 10, to 12, depending on the approach, as I said, anterior, posterior, and laparoscopic or ultrasound guided. The aim of the study, as all of the previous literature has compared TAP to local anesthesia, epidural to PCA, spinal to PCA or oral opioids, we aim to compare multiple of these adjunctive modalities at once to see if there was any superiority of one or the other or any association with improved outcomes. Also, prior studies were very heterogeneous without a focus specifically on colectomy. So we aim to investigate the effect on postoperative outcomes, if any of these things helped with ERAS compliance in other areas, length of stay, pain control, or readmission. As reference, this is our institution's ERAS protocol. I mainly just put it here for reference, but we do preoperative carbohydrate drink, we monitor postoperative nausea and vomiting, we have them mobilize in PACU, we look at if they used opioids in PACU, and if they used any narcotics throughout their admission, time to ambulation, time to bowel movement. We aim to get them out of bed within 3 hours of arrival time to the floor, and then we monitor if they had an NG tube, a Foley, how long, and all of those things as well, and VTE prophylaxis. So methods, this is a retrospective cohort study at a single community center, Boca Raton Regional Hospital in Florida. Multiple surgeons at that hospital all participated and contributed patients. Inclusion criteria was an almost 2-year period between 2019 and 2021. Our cases were tap block, spinal anesthesia, and our controls were general anesthesia alone, and all patients underwent the institutional ERAS protocol above. Inclusion criteria is adult patients with any colectomy during that inclusion criteria. We didn't specify because we wanted to keep our results generalizable rather than going into a rabbit hole. We did include emergency cases. None of those emergency cases ended up getting adjunctive anesthesia, but we included them in inclusion so that if they did, we could see if there was a difference in those groups. It included open and robotic cases. Our institution routinely does colectomies robotically. During the study period, we didn't have any laparoscopic colectomies performed. And we excluded patients that were under 18 and didn't have adequate data on the primary outcomes. Primary outcome, like I said, is postoperative complications, time to first bowel movement, disposition. Secondary outcomes are compliance with ERAS protocol, pain control, and length of stay. We collected the normal demographic data, operative details, postoperative complications as a binary yes or no, or any specific complication within there, use of opioids in PACU or use of narcotics during the entire hospital stay, and then compliance with ERAS protocols, length of stay, readmission, and where patients went on discharge. We don't have outcomes beyond 30 days in this study. Statistical analysis was performed with EZR. We used chi-squared and Fisher's exact for categorical, and student t-test or Mann-Whitney for continuous variables. We did initially an association analysis where any variables that were found to have a p-value of less than 0.1 and were related to our primary or secondary outcomes, then underwent a regression analysis, a univariable regression, where we reported an odds ratio and used p less than 0.05 as significance. 225 patients met inclusion criteria with an average age of 70 and a standard deviation of 14.5. Boca Raton is a very robust retirement community, so we have the benefit of having an older population and seeing if these interventions work in the frailer group compared to a young, healthy population. The average BMI was 26, 104 males, no perioperative mortalities. We had 55 patients in general anesthesia alone, 70 who got a tap block, and 100 who underwent spinal anesthesia. In terms of demographics, the groups were fairly well matched. The general anesthesia alone had a slightly higher proportion of patients with an ASA of 3, but not significantly different at ASA 4. Similar BMIs, age, and gender distribution. In terms of operative details, I've highlighted the ones that are significant. Like I said, emergency surgery, none of them got adjunctive anesthesia. Other than that, our institution also uses a clean closing table protocol to help prevent surgical site infections that you'll hear more about tomorrow. But we found that we utilized it more without the adjunctive anesthesia. I don't have a great explanation for that. I think it was by chance at our institution how that occurred, because it's not routinely used. It's selectively used by surgeon. In terms of compliance or complications, there were no difference in postoperative complications, infectious complications, urinary retention, nausea, or emesis between the methods of anesthesia. And postoperative course, this is where we notice some of our differences. The spinal anesthesia had a higher rate of PO intake in PACU. It had less narcotics used during the hospitalization, although it didn't differ in whether patients requested narcotics in PACU itself. They walked quicker after surgery, and their discharge disposition was more likely to be home or home with home health than a skilled nursing facility. In regression analysis, in regression analysis of significant factors, spinal anesthesia had an odds ratio of 5.375 for higher PO and PACU, 0.43 for lower narcotics used during the hospital course, and 0.03 for lower discharge to SNF when compared specifically to tap block with general anesthesia as the reference. So conclusion, spinal anesthesia is associated with increased PO intake in PACU, shorter time to first ambulation, lower narcotic use over the hospitalization, and a lower rate of discharge to skilled nursing facility, which multiple studies have shown increases your rate of postoperative complications, specifically within colorectal surgical patients. No difference in complications, length of stay, or readmission between the groups. So at our institution, we're now going to start leaning towards recommending spinal anesthesia over tap blocks as our adjunctive anesthesia within an ERAS protocol. And I will take...
I'm so sorry, we're going to have to move on just for sake of time.
That's okay.
But